Yeah, thank you, Naresh, for taking the time today. I broadly have four questions covering from, how the COVID-19 crisis, which has pretty much affected every single practice across the country, how it is affecting you at Huron Gastroenterology, and the steps that you're taking, in trying to tackle this crisis, and then finally, what you're doing at DHPA, what DHPA is doing. So if it's okay with you, I wanted to get started with the first question.
Sure.
So pretty much, everybody, every business, every medical specialty has been affected by COVID-19, and the last 2 weeks have really flipped the lid of all kinds of businesses. How has it affected you at Huron Gastroenterology, both from a clinical standpoint and as well as business standpoint?
Well, within 2 weeks, we went from one extreme to the other. We were having active conversations about recruitment and growth, and we couldn't keep up with the work we were doing. And we were actively engaged in recruiting new doctors to handle the work that we couldn't, that was a lot. And then within a day, it became full stop. We needed to shut everything down. We made a recommendation early on. Our board met, and we basically made a decision that we just needed to stop everything. So we were one of the first ones, I think, that made a decision to stop before the CMS guidelines about endoscopy. We just felt that if we had one patient who was COVID positive that entered our hospital, our ASC, or office, it could be catastrophic because then that person would have exposed our staff, other patients, and trying to track that patient down and trying to figure out how to stop this, we thought would be too difficult. So we made the difficult decision to stop all ASC procedures and then stop all office patients. We then needed to scramble and figure out how to do telemedicine, which we can get into a little bit later on.
Okay, but you told me earlier that a couple of your colleagues, did get infected, and how did that happen, and how did you deal with it?
Yeah, I mean, both of my colleagues who were rounding in the hospital, they were our first patient in the hospital was somebody who had gone on who had traveled abroad and then came in with respiratory symptoms. Historically, respiratory symptoms with cough and fevers and so forth were felt to be the symptoms associated with COVID. In our case, we had a patient who came in with GI symptoms. And so no one was suspecting that this was a COVID patient. So my colleague had went in and saw the patient as you would any other GI patient with diarrhea. And then 3 days into her stay, the ship that she was traveling in had called all the passengers and said, oh, by the way, a lot of the ship people who were on the ship were COVID positive. So then she alerts us, and then she was tested and subsequently was positive. By that time, unfortunately, she had been in the hospital for 3-4 days, not being suspected to have it. My colleague was taking care of her, and then so she was quarantined. And in the last week, I had a second colleague who, again, was rounding in the hospital, who was an incredibly fit person who, runs marathons and so forth. And then 3-4 days into his rounding week, became short of breath. And now he's isolated and so forth. So this is obviously impacting our workforce because we're right on the front lines.
Do you have enough PPEs available, enough equipment that you need?
No, we're scrambling. Every one of my partners and I, we have an N95 mask, but we're holding it dear such that we have to reuse it. So we do. So we treasure that like this. It's a family heirloom, and we try to hold on to it. And we're cleaning it well as we can. And the utilization of PPE is now being modified in real time. Initially, it was like, well, you just don't need anything, and you put a surgical mask on if you go into a person you don't suspect has COVID, and then you can put on your N95 in the patient that you do know. Now we know that it's very hard to figure out who has it and who doesn't, so it's almost universal precaution. We're just assuming everybody has it, and then we're trying to put on, our head covering, N95 masks, face shields when we're doing procedures, and gowns in procedures. But the trouble is that when you're in a hospital, everything from the keyboard to every doorknob you touch, and you're constantly touching everything. And it's very hard to really feel that you are completely protected. My colleagues who were affected, who were infected, they're very cautious. They were doing all the things you're supposed to do, and yet I think the viral load is so high and so prevalent on surfaces, and not only surfaces, but people around you, that I'm almost resigned to the fact that I'll get infected, and I just hope I can come out on the other side.
Yeah, I wish you all the best with that.
Yeah.
But what kind of a business impact has this had for your group and your surgery center?
Well, it's been dramatic. We went from being economically doing very well with our ASCs. We had 5 rooms running with 16, 17 cases a day, 5, maybe 6 days a week, to doing 5 cases a day. And those are the people that are urgent, that the cases we're doing are people we have high suspicion there's a cancer. Anything short of that, we're not doing. The same is true for the office side. We're trying to do telemedicine, but from never having done telemedicine to 24 hours a day, they're doing all telemedicine. You can just imagine the logistical challenge, all the inefficiencies that we have to kind of work through. So we're working through everything from drop calls to our patients not knowing how to download the technology, to how do you bill for it, and going through all of those codes and so forth. So it's been quite challenging.
What kind of tools are you using for telemedicine?
We're using Zoom for our patients, and however, the thing with some of the more technologically advanced procedures or technologies is that our end user, which is our geriatric patient, doesn't know how to download and run the operations. So we may start a call with an attempted call using Zoom or one of these other technologies. Sometimes I just break down and use FaceTime if the patient has a phone that can accommodate FaceTime. Otherwise, we just call. So then you get into the dilemma of, if you call them, is that a telephone call or is it a failed telehealth call? We've defaulted to the fact that if you made a good faith effort to do telehealth and then you have to switch to a phone because the patient is a Medicare patient who just doesn't know how to engage the technology, we're billing that as a telehealth call. And the guidance has been that we should be okay doing that, because this is a crisis, and hopefully CMS will give us a break as long as we made a good faith effort to do telehealth.
Yeah, I think that's what the notice from CMS also said. They expect that the physicians will do it in good faith, and I think they would be okay with that. What kind of cases are you seeing? Are these IBD cases, or all the cases are through telemedicine now, or most of them?
Yeah, we're really seeing everything from abdominal pain to nausea to constipation. And it's intriguing. I think this will, if there's something good that can come out of this, I think the fact that we will be able to scale up telemedicine is probably one of the good things, because it's frankly very convenient for the patient and very convenient for us. And I think most of gastroenterology is the history and counseling and so forth. As I know it'll break the heart of my med school teachers who taught us physical exam, but I can't remember the last time the physical exam affected my decision making in the office. In the hospital is different because somebody may have an acute abdomen and so forth, but in the office setting, people are coming with nausea, vomiting, chronic abdominal pain, constipation, reflux, fatty liver. And frankly, the physical exam is really not making me change what I do or what I assess. So the good thing is that I think most of GI can be delivered through telehealth, which I think will be a paradigm shift for us.
Okay. But then where you do need to see the response of a patient through a physical exam, or, when you're checking different systems, do you ask them to do it? And then do you navigate that at all? Or?
Yeah, interestingly, I think we could do most of it without a physical exam, because I think, if somebody that, for instance, has inflammatory bowel disease, we're asking, questions, did your stool frequency decrease? Did the blood in your stool decrease? Did your pain get better? So forth. And there's nothing to feel or touch because of that. I think if a patient, the rare patient who comes in and says, I have an abdominal mass, or, I have pain in the right lower quadrant. People with acute pain usually show up in the hospital. The pain is so severe that they come to the emergency room. People that show up in the office rarely show up with acute pain. It's usually, I've had this pain for 3 months, and, here are the tests that were done, they still can't figure it out, and that's why we get involved. So I think the majority of what we do can be provided via telehealth.
Okay. And now you are an executive committee member of the DHPA, the Digestive Health Physicians Association. And I've learned that DHPA is playing a very active role, with the stimulus package. The package itself is a $2 trillion deal, and it's historic in its own way. So I'm keen to learn, what DHPA has been doing, and what gastroenterologists can expect to hear over the coming days.
Yeah, I think DHPA has been a phenomenal force in getting independent practices like ours aid. The initial stimulus package was meant towards small businesses, and I think a lot of legislators don't see independent medical groups as small businesses. We're no different than a coffee shop or the local restaurant. We make money by seeing patients. We don't sell pizza. We sell medical care, and unfortunately, we're in the front lines of treatment. And because we shut down our medical practices, we have to furlough our staff, and so we are the army engaged in the care of COVID, and because of the financial impact of shutting down our practice, that army is lessened. That the army that is available to help COVID patients is lessened, and we thought that was devastating. So fortunately, we literally had calls every day and email exchanges and so forth. And fortunately, our lobbyists, we have a Republican lobbyist and a Democratic lobbyist, they were engaged in this conversation, and they said, "Oh my God, you guys are impacted in the same way as any other business." And fortunately, they were able to take that message to the people who are crafting the legislation. And I'm not overstating that fact, but our lobbyists were literally taking our experience and saying, "You're destroying the army that is there to help fight this crisis." And this is not economic crisis. This is a medical crisis that's leading to an economic crisis. So I think legislators, need to understand that, yes, it's economically devastating, and you're throwing money at airlines and so forth, which, they have the political muscle to go have, personal calls with the president and say, hey, give us 20% of the relief money. And, you see images on CNN with empty airports and empty planes and so forth, but there are not going to be any people to ride that plane if you don't have people surviving COVID. And I think you need to arm the people who are on the front lines who are actually taking care of the patients. And I think we were effectively able to make that case, and some of the money that was put aside was able to be segregated and sent to independent medical practices to support our ASCs, as well as support for keeping our staff hired and so forth.
Do you have any advice for GI doctors who might watch this, or administrators of GI practices who would be watching this?
Well, I think as in any crisis, I think we're trying to stay calm and hoping that, in a month or two, we'll be able to come out of this. I think the most exciting thing is, this new bill is, 48 hours old, and we're trying to wade through this. And I think the good news is that there is going to be support for staff, as well as ASC lost productivity. So I think we need to go through the law very carefully and basically see how we best can use the laws and the subsidies that are being given by the government to keep our business running. And and the good thing is that there's forgivable loans that will go towards our staff. And it looks like there's going to be support for some of the lost cases that we got from the ASC. So in the next 24, 48 hours, we're going to see how best to apply that law and to our practice, because there are some timing issues. When to optimize getting the loans, what parts of it should be grants, what part of it should be loans. Do you furlough patient employees? When do you furlough? Do you not furlough? When do you bring them back? So these are the questions that we need to kind of work through. But I'm optimistic we can get through this, and I'm hoping that this whole experience is going to make us leaner. And as we've spoken, some ways that we deliver care, like telehealth, I think will be a paradigm shift for how we go about doing business going forward.
Okay. Yeah. Thank you so much, Naresh, and I wish you well, and your colleagues too, and stay safe.
Yeah. No. Thank you. Thank you.